I want to switch over now to the good risk, because in some respects, this is a harder population. We have less data in the good risk, specifically good risk population on some of these regimens, and yet there is some data here. So, Rich, do you want to walk us through a little bit of some of the sort of good performance status data that's out there?
This is also a major challenge for me in the clinic too, because a lot of patients come in having read the New York Times, 60 Minutes, whatever, immunotherapy. Everybody wants immunotherapy, and while I agree it's been great in intermediate poor, when you look at least Checkmate 214, it seems to be inferior. Maybe it's still, the statistics aren't there yet, but immunotherapy might be. And certainly in my clinical experience, when we had patients on study, specifically emotion, Atezo-Bev versus Sutent, some of my favorable risk patients are still on study with Sutent 3 and 4 years later. Now, so I think that exactly echoes what Walt was saying. Some of these patients that do so well with VEGF TKIs, it's really hard to put them on something that may not have as good of activity, even though it's not. We know it's not VEGF, are not curative, right? That's why we kind of think about more with the IOs. So it is a big challenge. And but I do believe in sticking with VEGF TKIs in my favorable risk patients.
Well, I mean, I may want to point out, as the one who has been around for long enough to get some gray hair, is that the some of the original studies in terms of risk factors were from Memorial, and in the era when the only drug we had was interferon, essentially, which, as far as I'm concerned, is a toxic placebo. There were 10% of patients with good risk that were alive 10 years later on, with essentially no therapy. So I think that the most difficult conversation in the clinic are these very good risk patients, these patients that show up with several lung nodules 10 years after the nephrectomy because someone did a chest x-ray, they're feeling great, they're wonderful, and I have to have a conversation with them that the best thing to do is get another CT scan in 3 months and not any of my poisons. I think it's a hard discussion, but I think it's the right discussion.
Well, you were part of our MARC registry, yeah. So we had some lessons learned from that, and one of them was around this practice of deferred systemic therapy and exactly the kind of population you just described. What are your takes on how to advise community doctors on what's the best way to identify somebody appropriate for deferred systemic therapy?
Well, and I think these risk categories help. So if there has been a long interval since the nephrectomy, more than 3 or 4 years, if there is a low volume of disease, a few nodules and metastatic sites, patient is completely asymptomatic, the labs are all completely rock normal, some of those patients are going to be best served by just observation. And I think that if you see a patient like that, the first thought should be, when do I do my next CT scan, not which drug do I pull off the shelf.
And pathology has a significant influence. If you're in a clear cell without rhabdoid or sarcomatoid features and maybe a modest clear cell, that's going to enter the decision too. Mm-hmm. If you're a chromophobe, slow, that's indolent, that's going to enter decisions too, as far as how aggressive one needs to be. Papillary is the same, type 1 or type 2.
So Toni, what do you think about that? So Bob brings up pathology in the good risk patients, and PD-L1 is a marker in this disease. It's a prognostic marker.
I think PD-L1 to the biomarker field is the same as kidney cancer to the internist. I think it's very muddy, and I think we have to be very, very careful, not just across tumor, even inside renal cell. Different cutoff, different definition, different antibodies, different disease, and sometimes conflicting results. So I'm glad that the future studies, starting actually with 214 and on, are considering strongly as a co-primary endpoint or looking at PD-L1. We will learn, from that. But even with 214, I am not sure staining for PD-L1, if you want to use the same test that, the company used, if you have access to it, is going to be very important. Perhaps in a patient where they really want nivo-ipi and there is some relative contraindication, but they are intermediate poor, they have high, PD-L1 expression, we know in these patients the response rate is 58% with 16% rate of CR. I may consider it, but it may not be the same PD-L1. From a test to another, one by a company will be positive, another one negative. How the PD-L1, done, that is, a problem. So I proceed extremely carefully, and it's not part of my routine testing at this point.
And it gets even more complicated because the community oncologist is dealing with all the lung cancer patients, where we now have even different cutoffs and different descriptions of what PD-L1 positivity means. So I think it's going to be more confusing over the next few years than clarifying.
And there is a lot of pathologists now issuing statement where it's not clean that it's negative or positive. It is, not conclusive.
Yeah. And I think that's really the best advice here, that this is really not ready for kind of clinical recommendation as a standard practice yet. But I hope that evolves.
And I think even when I treat patients with melanoma as well, I use it as one of many different factors. It's never like the factor that makes you decide one way or the other.
Fantastic. And Rich, just as a final point, so we've talked about cabozantinib and we've talked about sunitinib. Are there other VEGF-targeted therapies that have been studied in this sort of good risk population that, would be appropriate choices there?
Yeah, I mean, I think, we've talked about Votrient, and I think that is one of the, in my experience, least toxic, and we know that from compares that at least most of the patients did seem to do better on that compared to sunitinib. So that's usually my go-to on the front line.
Yeah, I mean, there are other TKI out there we cannot, exclude, not just tolerability. Lenvatinib in combination with everolimus, very impressive activity second line versus, in patient progressed on sunitinib. And this drug is being combined with pembrolizumab in a large trial. We can't ignore axitinib, a drug we have, a great experience with, especially with the dose escalation by 1 milligram. I've seen some patients not respond on 5 BID and respond to 7 BID, back and forth, and the therapeutic window is very short. And this drug is being combined with 2 checkpoint blocker in the first line setting. So there are other things I consider, though axitinib is not approved for the front line setting.